aldosterone blocker, and then if you come up with a new drug, people are going to expect you to give everybody that new drug on top of it versus placebo, on top of all this other stuff. And that's cumbersome too, because trying to ensure that people are on this stuff and then in addition have to take yet another drug is a problem. But it does mimic clinical practice. It's ethical. It's just expensive and hard to do. And the other bad thing, of course, is that if people are optimally treated in your trial, which is what you really want ethically, then the event rate goes down, right? If you can enroll a whole bunch of people who are on none of these medications, your event rate would be much higher in the placebo group, and your sample size would be much smaller, and it would cost a lot less. All right, choice of control. So, as I've said, an inner placebo blinded is usually the best choice. If you're going to do a placebo, an inactive control, then the null hypothesis is that there's no difference between the two treatments, right? There'll be no difference between the active and the placebo. And the alternative hypothesis is there is a difference in either direction. Now suppose, and this is what Wendy was asking, suppose you want to have an active therapy control. That is, there's a good treatment out there for whatever condition you're worried about, and you feel it's only ethical to randomize to your new treatment compared to standard care. In that case, this would be called an equivalence trial. That is, you're not looking to see generally if you're looking to see whether your drug is better than standard care, that's a standard trial. Okay? But if you're just wondering if your drug is as good, then that's an equivalence trial. Now, often you're mostly worried that your drug just not be inferior. And so you can set that trial up so it's one-sided, and those are called non-inferiority trials. So there you're interested in whether or not your drug is inferior, but you don't want it to be inferior. And when you think about this, what happens is the null hypothesis and the alternative hypothesis just kind of get flipped on their heads. So the null hypothesis here is not that there's no difference between the groups. It's that there is a difference. But you have to say how much difference. So there's not more than a stated difference between the groups. So you could say there won't be more than a 10% difference between the groups. Or there won't be more than a 5 milligram per DL of HDL difference between the groups if I treat with my random statin versus standard statin. So you have to, there's no way to do this statistically unless you specify that interval. And then the alternative hypothesis is that the difference will be more than that. So if you say, I want my drug to be within 10%, and it turns out that your drug is 20% worse, well then you have to reject the null hypothesis and your drug is inferior. Okay? Now these equivalence trials have the advantage, in my view, that they give a better answer to a clinical question. I do not really care if there's a 10 statin on the market that is better than placebo and costs a whole lot more money. What I'd really like to know is does that drug as good as the ones that are already out there and have any other advantages? I mean, maybe it'd be as good as the ones that are out there and be cheaper. Or maybe it'd be as good as the ones that are out there but have no possibility of causing any side effects or something like that. That's a good question. I think that also makes them more ethical. The disadvantages are, and everybody will tell you this, the disadvantage is that it may require a larger sample size because the outcomes in the people treated with the standard of care are not likely to be as common as if they weren't treated with anything at all, that is placebo. The other disadvantage that people don't talk about much is that a negative result could be due to low power. What does that mean? Well, let's say I have a new statin and I want to prove it's just as good as, I don't know, lovastatin. If I were to randomize 10 people to my drug and 10 people to lovastatin and compare their cholesterol values in a week, they'd be the same, right? Because the power to show that they're different would be squat. So the easiest way to show equivalence is to do an underpowered trial. So when you read these equivalence trials, you have to make sure that they're powered enough to show you that they're equivalent. If they say they're equivalent, but the confidence interval around that is huge, well, yeah, they're equivalent, but within this range. You really want them to be equivalent within a range that makes it sense for you to choose the new drug rather than the old one or the standard of care. Do you all understand that? Okay. And the other disadvantage that is that you can't tell whether either one of them is better than placebo. So if you're going to use a standard of care, it better be a pretty well-established standard of care. Otherwise, they could be equivalent because neither one of them works. Yeah.
But you always do a power analysis before you do a trial, so how is this power analysis different?
The equations are a little bit different because you're not looking at the power to show a difference. You're looking at the power to show no more than a certain equivalence. It's done the same way. And you will come out with a power calculation that says I need 100 participants per group in order to show that my drug is no different than the standard of care with this much confidence. Because if you said you wanted it to be exactly equivalent, you said I want to show my drug is exactly equivalent to the standard of care, what would the sample size be? Infinite. You can't do that. And if you said plus or minus tiny little confidence interval and the sample size is huge. But what this means is that, my last point, it is only reasonable to do this kind of thing, to study a new drug compared to a standard of care, if there's some potential advantage to the new drug or the new intervention, right? Because if there's no advantage, you don't want to give up any efficacy. You want it to be just as efficacious as the standard of care. But if you're willing to spot that standard of care a little bit of efficacy because your drug is so much better, that is, it's just once a day, or it's really cheaper, or it has no side effects, or something like that, then it's worthwhile. Let me give you this example. Let's say I'm developing a new antidepressant drug. There are lots of antidepressants out there already. And we also know that depression is a bad illness. People with major depression commit suicide, and they do it more commonly within the first few months of being diagnosed than later. So they really should be treated. So I think ethically it's kind of unethical to do randomized trials of new depression drugs and use placebo for control. But it's still pretty commonly done. Good drugs are selective serotonin reuptake inhibitors. They tend to work in many people. But they have lots of side effects. And one of the most distressing to many people is it often causes a complete lack of libido. So that's a main side effect. So let's say I've got a new drug, and I think it's just as effective as the old ones, and I think it's going to have no effect on libido. That's its potential advantage. And I'm going to call this drug Smiletrelene. And I want to do a placebo-controlled trial. If I want to do a placebo-controlled trial, right, I randomize my major depressive patients to Smiletrelene or an old drug, say sertraline, which is Zoloft. I expect a 25% improvement over placebo in depression scales, like the Beck Depression Inventory. My null hypothesis is there'll be no difference in change in Beck Depression scale in the two groups. And the alternative is that they'll be different. And I use an alpha 0.05 and beta 0.9. And the sample size would then be 100 per group under those criteria. Let's say instead we decide to do an equivalence trial and we want to compare Smiletrelene to sertraline. So now I'm going to randomize them to the new drug or just to sertraline. And the null hypothesis is that the difference is no greater than plus or minus 10% in change in their Beck Depression Inventory scales. Now I'm saying now that I'm willing to spot, sertraline 10% in terms of efficacy because I think my drug has no side effects. So the alternative hypothesis is that the difference will be greater than 10%, and the sample size that you can calculate from this winds up being 125. So it's bigger, but it's not huge, nor do I think it's prohibitively bigger. Now, if my drug had no advantages, and I said I wanted to be plus or minus 5% as good as sertraline, then the sample size winds up going about 200 or 250 or something. So this is just a little summary, but I think blinding is clearly as important as randomization for preventing bias. And due to these things, we talked about co-intervention, outcome ascertainment, and outcome measurement. It's actually difficult to accomplish. And if it's not possible, you really need to then just try to do your best to minimize these bad outcomes associated with unblinding. Choice of intervention. So you've got to trade off benefit and risk. And please try to think about interventions that are generalizable to clinical practice. And after that, then, interventions that allow you to strengthen your trial design, particularly recruitment. If you make your intervention difficult, time-consuming, unpleasant, you're going to have a really hard time recruiting people to use them. In terms of controls, placebo is generally the best. You should try hard to come up with some sort of a placebo control. and then consider equivalence if there's standard of care.